This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, this is yet another case of a phacolytic glaucoma in a 65-year-old lady. Even with all the anti-glaucoma medications and topical steroids, the pressure was refusing to come, and even on the day of surgery, with all these medications, the pressure was still hovering around 49, and after IV mannitol, the pressure drops down to around 30, but still I needed to do the surgery because that was the definitive thing which is going to help this patient. So in this case, we have a couple of challenges. One is the visibility is not great because the cornea is steamy and the raised pressure for some duration of time. Apart from that, the usual suspects, that is the free-floating nucleus and probably a compromised zonular apparatus. As the patient is being shifted to the theater, I'm still not sure about the health of the zonules, and I have not yet made up my mind whether to do an Phacoemulsification or SICS. I'm going to decide this on the table itself after judging the zonular health, and this is going to be apparent when I'm trying to do the rhexis. So once the capsule is stained, I'm intentionally making a scleral incision, and this is going to be a sclerocorneal tunnel incision through which I'll be performing phacoemulsification. If the situation demands that the zonules are not healthy and this is not a safe case for phacoemulsification, this same sclerocorneal tunnel I plan to enlarge and convert it to a manual scleral tunnel incision wound so that I can extract the nucleus manually. I will come to know the zonular health only when I start tearing the capsule. As I puncture the capsule, the fluid comes out, which is expected. BSS is used to irrigate it out. The chamber is filled with OVD. Time to perform the rhexis. In such eyes, I always prefer to use a rhexis forceps. As I'm holding the forceps and beginning to tear, I can feel that the zonular health is quite good, but I am also mindful of these calcific spots which are more in the mid-peripheral region all around in the anterocapsule. Presently, my goal is to fashion a rhexis, avoiding these calcific spots. So I'm trying to be within these areas of calcific spots. Of course, I'm going to end up having a slightly smaller rhexis, but I expect a smaller nucleus as well. Let's see how things turn out. So I have a rhexis which is about 4 mm now. But the good thing which I was happy about was the zonules were definitely healthy, and I have decided to perform phacoemulsification in this eye. The second side port is now created. Since it's a slightly denser nucleus, my settings are slightly different for the chop maneuver. So this is a free-floating Morgagnian nucleus. To minimize torque, I'm placing my sharp chopper nearer the equator of the nucleus, because this positioning is going to ensure that during the chopping and the lateral separation maneuvers, the torque will be slightly minimized. Although, mind you, this is not a horizontal chop wherein I'm not using a blunt chopper. This is still a sharp chopper. I'm just keeping it a little bit near the periphery. Of course, again, more than a couple of attempts are required to break the posterior plate. During these lateral separation maneuvers, it's important to not to push the nucleus, which is held by the phaco tip downward. It's always mandatory that the phaco tip which is engaging the nucleus should be pulled anteriorly. By doing this, during this maneuver, we don't exert stress on the posterior capsule. The posterior capsule, mind you, is going to be extremely thin in such eyes and is very vulnerable for rupture. So during the chopping and lateral separation maneuvers, the most important principle to follow is that the nucleus which is held by the phaco tip always needs to be pulled anteriorly, that is towards the surgeon, while the chopping and the lateral separation maneuvers are being done. The tip is slowly buried until the entire length up to the sleeve is buried into the substance of the nucleus. Then the chopping maneuver is begun. During lateral separation maneuvers, again the phaco tip holds the nuclear fragment and pulls it anteriorly so that the stress on the capsular bag and the posterior capsule is minimized as the fragment is being separated. Once there is a free fragment, it is pulled out of the bag and then emulsified at the level of the rhexis margin. There is still some attachment between this heminucleus and the remaining fragment. The nucleus is flipped and the chopping is done from the reverse side. Now we have these 3 smaller fragments which are then comfortably emulsified. The second instrument, as the chopper, again acts like a shield, preventing the lens fragments from jumping out and hitting the corneal endothelium. The nucleus emulsification process was relatively easy, primarily because the capsular bag had healthy zonules. In this case, I've decided to enlarge the rhexis before putting in the intraocular lens itself. So the OVD is used to deepen the chamber, and then going through the main incision using a micro scissors, a tangential cut is given to the rhexis margin, and then the flap is held by the forceps and the rhexis is enlarged. A foldable intraocular lens is placed into the bag. The OVD both in front and behind the lens is aspirated out. Diluted triamcinolone acetate is irrigated into the antechamber just to rule out any transzonular migration of vitreous. Thankfully, there is none. Time to close. And these are the first day post-op pictures. On the first day, the intraocular pressures were still reasonably high. It's around 30 millimeters of mercury. And the patient was continued with anti-glaucoma medications for the next few weeks. And on the 4th day, the pressure has reduced and now is normal. The patient has got excellent post-op visual recovery and she's very happy with the vision. So to summarize, in such cases, performing phacoemulsification is not very difficult, provided the bag and the zonules are healthy. The bag and zonules are healthy, then even with the small floating nucleus, we can emulsify the nucleus quite easily. But things get complicated when we have zonular dehiscence or zonular weakness. That's a situation where we may have to resort to a manual small chin cataract surgery. That was it. Thank you for watching and hope you found this helpful.